Bronchiolitis. This is a viral infection of the lower respiratory tract in infants and the young children, characterized by the inflammation, edema, and mucus production in the bronchioles, leading to the airway obstruction. Most common in the children less than 2 years of age, especially those less than 6 months. Peak incidence in the winter and the early spring. Leading cause of the hospitalization in the infants. Respiratory syncytial virus. This is the most common cause, nearly 50 to 18% of the cases. Other viruses like rhinovirus, parainfluenza virus, human metapneumovirus, influenza virus, and the adenovirus. Host factors like age less than 6 months, prematurity less than 37 weeks of gestation, underlying chronic conditions like example congenital heart disease and the bronchopulmonary dysplasia, immunodeficiency. Environmental factors like exposure to the tobacco smoke, crowded living conditions, and the daycare attendance. For the pathophysiology, the viral infection of the bronchioles leads to the edema and inflammation of the bronchiolar walls, excess mucoproduction, necrosis of the epithelial cells resulting in the airway obstruction, narrowing of the airways causing the air tapping and the hyperinflation, impairing the gas exchange. Clinical features like initial symptoms, upper respiratory infection, rhinorrhea, nasal congestion, low-grade fever, and the cough. Progression to the lower respiratory tract symptoms, tachypnea, wheezing, and crackles on the auscultation, use of the accessory muscles, nasal flaring, and the intercostal retractions. Cyanosis of the apnea in the severe cases, especially in the young infants. Diagnosis, clinical diagnosis based on age, season, and the typical symptoms. Investigations not routine only in the severe or the atypical cases. Viral testing, RSV antigen or the PCR in the hospitalized patients. Chest X-ray measures hyperinflation, patchy or the peribronchial thickening, not routinely required. Pulse oximetry to monitor the oxygen saturation. Blood gas analysis in severe cases with the suspected respiratory failure. For the management, supportive care, hydration, ensures the adequate fluid intake, IV fluids if oral intake is poor. Oxygen therapy for SpO2 less than 90% of the signs of the respiratory distress. Suctioning to relieve the nasal obstruction. Pharmacologic interventions like nebulized hypotonic saline may reduce the symptoms in the hospitalized cases. Bronchodilators not routinely recommended but may be trialed in cases with wheezing. Corticosteroids not recommended in the routine management. Antibiotics only if secondary bacterial infection is suspected. Hospitalization indicated for the severe respiratory distress, apnea or the cyanosis, inability to maintain the hydration, comorbidities like prematurity chronic lung disease. Prevention, hand hygiene critical to reduce the transmission. 12 weeks of prophylaxis for high risk infants, prematurity less than 29 weeks, chronic lung disease, congenital heart disease. Monthly injections during the RSV season, avoidance of the tobacco and smoke. Complication, respiratory failure requiring the mechanical ventilation, secondary bacterial infections like pneumonia, otitis media, long-term sequelae like increased risk of recurrent wheezing or the asthma. Bronchiolitis, this is the most common lower respiratory tract infection in the infants. RSV is the leading cause, peaking in the winter and the early spring. Typical symptoms like the rhinorrhea, wheezing, tachypnea, and the respiratory distress. Diagnosis is clinical. Tests like RSV PCR and the chest X-ray are not routinely required. Management is supportive. Oxygen hydration and the nasal suctioning. Corticosteroids and the routine bronchodilators are not recommended. Palliative prophylaxis is given to high-risk infants during the RSV season. Complications include respiratory failure and the long-term risk of the asthma.